Hi, Assalamualaikum. I'm Nurul Yakin. To appreciate something is to understand its worth. A father, with his sweat and tear, saved up money to buy his first car, a Myvi. Then he upgraded to Tesla as he progressed in his profession. No one could understand or value the old Myvi but himself. I think the knowledge endures the same way. As we understand and comprehend a difficulty, a struggle, laborious effort, and sacrifices involved in the advancement of a knowledge and technology, we'll appreciate them more. I have the honor of speaking to one of the pioneers of IVF in Malaysia. The field has evolved and progressed so much since the first born of successful IVF treatment back in 1987 by Dr. Haris Hamzah. Dr. Haris Hamzah is now works in Alpha Fertility Center, a public listed company, and a medical director of Alhaya Fertility Center in Damansara Specialist Hospital too. So let's join me.
Okay, 1978, the birth of Louis Brown. I think everybody in this field is very, very familiar with that story. And it was the year that I had just finished my housemanship and was starting my first year as a medical officer. So the early years of my training, I had the opportunity to work in UKM unit, HKM, and it was that time that I was exposed to doing ultrasound in those early days. In those early days, the first ultrasound that we had available was the Nuclear Enterprise Diasonograph, which is a very big static scanner, unlike the scanners you have today. Those 78, 79, that diagnostic laparoscopy was just introduced at that time at LPKM. And it was only later that we started to use the Aloka early linear array scans. So those were improvements in technology available to us in those days. Okay, so having completed my MRCOG in 1982, I stayed as a lecturer with UKM, and my interests covered basically fertility assessment and treatment, tubal and pelvic microsurgery. And I stayed with UKM until 1985 when I left for private practice. And it was soon after that that I had the opportunity to meet with now Professor Dr. Jovic in the Pivot Infertility Center in Perth, West Australia, and arranged to have training with him in IVF at that time. So it was during the course of that training that we were discussing the feasibility of setting up an IVF unit in KL. Dr. Jovic is a graduate of University WA in 1970, and he had his reproductive training in the UK from 76 to 80, working with Prof. Ian Kraft and also in Bourne with Steptoe and Edwards in Cambridge. And in 1981, he set up the first private IVF unit in Perth, Western Australia. And they delivered their very first IVF baby in 1982. So it was a great fortune that I had the opportunity to work and train with them. And ultimately, we initiated the IVF service here in Kuala Lumpur at Subang Medical Center in early 1986, in January. And essentially, it was based on a transfer of technology and with our staff recruitment locally, but trained in Australia. And we were using the available infrastructure at Subang Medical Center at that time. So in those early days, it was really very ad hoc in many ways. We do not have the current sophisticated laboratory setup as we have today. We at that time used a part of the daycare center where we had a small laboratory set up, and we had to use a mobile mini laboratory to be wheeled in and out of theater to do the pickups and transfers. And in the first year of doing IVF, our biggest problem was media logistics at that time. We had to import our media from Australia and had to arrange for a complex logistic arrangement through customs, etc., and trying to keep a cold chain flowing at that time, which wasn't the easiest of things to do. So the other challenges during that time was obviously the training, being on site and both in Perth, West Australia. The team had to travel up and down for training. And in the physical part of the setup of the lab, the biggest problem was maintaining the environment and temperature in terms of from laboratory to OR. And our theaters there were notoriously difficult to control temperatures to a satisfactory, warm enough temperature. So that's one of the biggest challenges. Now, you may not know, but in those days, we were not monitoring patients like we do nowadays. We had to depend on daily blood tests for radioimmunoassays to measure the hormones E2, P4, LH, and for monitoring and follicular growth. We were not relying on ultrasound scans at that time. So it was very tedious in a way, and we had to set up our own radioimmunoassay laboratory and have a radioimmunoassay license. And we monitored everything daily with blood tests, and we applied what we call a 6-day rule or algorithm to determine when was the appropriate time for triggering the LH surge for egg pickup. So as you can imagine, we were not using scans, so we don't see like today that you're watching the follicular development and trying to reach a follicle size, which we are nowadays predetermined. Okay, that was one of the early things that we had as difficult issues. The other thing was, of course, there was no downregulation at the time. There was no agonist available. And most importantly, at that time, in the early days, we had not set up our freezing facility yet. So, as you can imagine, we were limiting our stimulation, low-dose simulations, using a combination of clomiphene HMG, trying not to develop more than 5 or 7 follicles per cycle, so that we could avoid supernumerary embryos that we had no freezing for. So it's always a very tricky balance. And the other complicated thing at that time was all OPUs were done via laparoscopy. It wasn't transvaginal pickups like now. So we used a laparoscopic approach to aspirate all the follicles, and you physically could see the ovaries and aspirate the follicles. Of course, it would have been difficult when you have patients with adhesions in the pelvis. It makes it even harder to do that. And of course, at that time, our culture systems were limited to cell stage cultures up to day 2 or day 3, and then transferring at day 2 or 3 when they were either 4 or 8 cell embryos. And those early days, of course, it was basically a blind embryo transfer without ultrasound control. So I guess in that respect, overall of these issues, it kept our results pretty low. Having said that, in the early period of our experience, we were achieving about 25% pregnancy rates at that time. By 1978, however, in the late part of 78, we had the opportunity to then reintroduce GIFT program. Again, I think for a lot of younger doctors today, you will not have experienced that particular program. It still involved a basic low-dose protocol. Again, we were limiting the number of oocytes we produced. It was a laparoscopic oocyte pickup. You identify the mature oocytes and you load it into a catheter and then transfer it into the fallopian tube with fresh sperms which have been pre-prepared. And one of the earliest interesting part of that program in that time was it immediately gave us an improvement in pregnancy rates. So we were achieving up to 40% pregnancies with GIFT at that time. But as you can imagine, the GIFT program, you were limited to doing, particularly in younger patients with normal fallopian tubes, or at least one patent fallopian tube, and basically normal sperm, okay, to achieve those results. So even in those days, patients with bad sperm quality were very, very difficult to treat. We had tried various things to try and improve sperm motility in those days, but not with much success. Okay, so up till the year 2000 onwards, we had developed, upgraded our system in the theatre. We managed to get one whole operating theatre to completely convert it into an IVF laboratory, which is better for temperature control and sterility and airflow. And there was adjoining a separate theatre for OPU and embryo transfers, with separate semen as preparation rooms. We had also begun our freezing and storage program from 1990. So at that point in time, with freezing, although at that time was still slow planar freezing, we at least were able to offer that service for those with excess embryos. Oocyte freezing was not on the cards at that time. So the progression from, not just laboratory equipment, but ultimately converting to transvaginal egg collections. And I still remember my very first transvaginal egg collection was a very crude affair. We had our first transvaginal scan, which at that time you didn't have a guide marker, and you had to rig your own needle on the probe to achieve it. And that time we used a straight needle to just aspirate freely. So it was a learning curve at that time, and ultimately when we did get to the proper kind of probes with needle guides, it became much more with better egg pickup rates. So by that time in the early 90s, we were able to move from gift to full IVF for all patients. Because we were confident enough, because our results were then improving for the IVF patients. We went up to 35 and then 40%. So all the patients were now able to do full IVF. But although at that time it was still cell stage transfers. Okay. In 2004 was when we then introduced ICSI as a solution for the treatment of patients with severe sperm problems. And we achieved the first pregnancy from testicular aspiration, sperm aspiration with ICSI, and successfully get them pregnant. So with that, by that was in 1994, sorry, that the ICSI set up. But it wasn't until early 2000 that we finally managed to get into blastocyst cultures, and which has now become the ultimate stage for transfer. Okay. During all these years, of course, you are aware that there has been advancements in the pharmacological side of things. So from the early days of just Clomid and the crude urinary gonadotrophins, we went to highly purified gonadotrophins, and then in the late 80s, 1989, that the agonist buserelin became available and used as a nasal spray for downregulation. So then we started using it as long protocols. We were better controlling the LH surge, better scheduling. And ultimately, in early 90s, we changed it to a subcutaneous agonist administration. The other thing was, of course, the available gonadotrophins, as I said, from the initial Pergonal HMG prophecy back in 1985 to the 1990s. We went on to then purified FSH, urinary FSH, like Metrodin or Humigon in those days. And then in the early 90s, we went to the highly purified urinary gonadotrophins, and which was better suited for what we needed. And we transferred or transformed from the early days of deep intramuscular injection to at least being able to give it subcutaneously, which was advantageous for the patients, obviously, because they could then utilize it as a subcutaneous self-administered injection. In the mid-90s, the coming of recombinant FSH, I was able to do our first experience with Puragon here in Malaysia, where we then presented the data from the Puragon trial that we did. And then the development of other gonadotrophins, recombinants like recombinant LH, Luveris and Ovidrel, and then Gonal F and the other products that we are now currently using. So we have evolved from the early days of being very, very crude laboratory processing to something much more sophisticated in the laboratory and also more sophisticated in the pharmacological side of things, and allowing us to be able to monitor patients much more simply with not as intense kind of daily monitoring that we used to do. So we're now in the stage of doing ultrasound assessment and monitoring, as you all are aware of, where we can also use that nowadays to better assess the antral follicle count as well as follicle development. So we're obviously less dependent on hormonal monitoring than before. And of course, with transvaginal ultrasound pickup, is much better access and very efficient with minimal complications, when done with experience. We also now have better endometrial assessment for endometrial thickness, polyps, and so on. And now with ultrasound-directed transfers, which replace the blind transfers of before, which you have better placement of embryos, which is less traumatic. And also, remember, nowadays we use a much smaller volume for transfer. Nowadays, we also use AMH as a marker for PCOS management. And with the current management that we have cut out a lot of issues from ovarian hyperstimulation, which we experienced more in the early days. So we are much more able to control these issues. For example, if you have a patient who unexpectedly responds with very high response and high number of oocytes, we now can actually freeze the oocytes or freeze the embryos or split the number of oocytes you fertilize, and then don't transfer them until another cycle when everything settles down, so that it avoids hyperstimulation during stimulation or after a transfer if they got pregnant. So today, nowadays, we now have in this country standalone ambulatory care centers for infertility, like our own center. That means you have your own setup, be it in a shopping center, be it in a separate building, where you have everything from your clinics, counseling centers, your laboratories, your operating theater for OPU and transfers. So nowadays, of course, we have a better trained group of clinicians, scientists, counselors, and support staff, which is very, very important at the end of the day to cater for your patients. We have a better understanding of IVF protocols. We have better designed clean room IVF facilities. We have closed systems for embryo and oocyte handling and culture, like embryoscopes, and very strict quality control and standards. For example, in our labs, we use the RTEC standards to maintain our license and control of our work. We also involved in a lot of R&D, and we have in our labs done a lot of research and presentations overseas. Of course, ultimately, we also provide genetic screening nowadays, which has been useful, but it must be in a selected group of patients. And now we are looking at things like endometrial assessment using EndoTrio, as you may be aware. And we are looking at other issues or methods like endometrial PRP, ovarian PRP, all these to enhance either oocyte pickup or try to ameliorate issues with endometrial issues that may affect implantation. So generally, I mean, I've just given you a very quick overview of what has happened from the time I started back in 1980s. 86. Let me see if there's anything else I missed out. Had a very good opportunity from those early days. We started in 1986 and delivered our first baby in 1987, IVF pregnancy. It's not a very long period of time, if you can imagine. It's about 38 years. But we have seen an immense improvement in all aspects of infertility treatment,